So, welcome to the Hospital Systems Addiction Care Community of Practice. Lucy Hodder and I have known each other for many years. I have been delighted to make her acquaintance and part of the arc of her career, which has carried her from from private practice early in her 30-year career in San Francisco and in a New Hampshire firm of Rath, Young and Pignatelli to the governor's office, where she was the legal counsel to Governor Maggie Hassan and senior healthcare policy advisor and a very prominent figure working in the state's healthcare landscape. This applied in many cases to mental health and substance use disorder. And she is currently holding the position of Director of Health Law and Policy and has been a distinguished visiting professor of law at the UNH Franklin Pierce School of Law. She's also a consultant to the Institute for Health Policy and Practice, and she has a very robust presentation. Lucy has a high degree of confidence in our ability to get a lot of to absorb a lot of information in our hour. So, I think I have hit the high points of a very great bio, and I think at this point I turn it over to Lucy.
Great, Dan, and hello, everybody. It's great to be with everybody today. And I just want to say we're going to get through a lot and learn a lot. And I hope you all are active on the chat function and that we can really achieve some objectives about learning what is new around substance use, treatment record disclosure, and just also brush up on what we all know. I can't tell you how often I hear, wow, I can't do this because of HIPAA. I can't do this because of Part 2, when in fact, maybe you can. And so we just want to talk about what people know, what people have questions about, and get ready for the new regulations coming down the pike. Just want to make sure that it's clear I am not giving legal advice, and I am not anyone's attorney. You may have great attorneys, so go to them and your compliance folks if you have questions about what we discuss. And this is my own presentation. It's not the University of New Hampshire's. I also, many of you may have seen me presenting at the Behavioral Health Conference last week with attorney Lori Beth Pliakos, who is both helps me teach in the health law program, and she also is at InStride Health. So to the extent she was helpful in any of these slides, I want to thank her. Next slide. So what we're going to do today is we're going to just do a little confidentiality primer, get us in the game, get our minds in this, and then also talk about the new rules. There are 42 CFR Part 2 new rules consistent with a statute. So we knew these were coming. We knew a little bit about what they might do. They have made life easier, but not completely. Then we're going to do some hypotheticals, and those I want you active in the hypotheticals using the chat function, if you can. And then we're going to talk a little bit about some of the emerging issues in privacy. Next slide. I just want to make sure we all know that privacy means so many things to so many people. And I'd love to be able to have you think about something and think about your health, your own health and your own health care. What is something private that you would want to share and put in the chat? Don't put it in the chat. Just think about something about you and your health that you would share with somebody. And then the question I have for you, if you have that in mind, is how do you feel about sharing that? How do you feel about sharing that and then sharing that further? Someone tells someone tells someone. What makes you uncomfortable? I know for me, what makes me feel uncomfortable is once you've rung that bell, once someone learns something about you, whether it's that you've had cancer or that you've had treatment for mental health or that you've had heart issues and are at risk of heart attack, whatever it is, that you have no idea what kind of stigma might be associated with that and where that information goes. So I do think it's really important when we talk about privacy to think about ourselves, think about our family, think about your sister's kid who ends up in the ER after a party brought by a friend. with substance use. Think about, your cousin who's getting ECT treatment. Think about your mother who may have early Alzheimer's. What are the kind of things that you would want to make sure are private? Who should be in on those conversations? What is the stigma? And then, New Hampshire has this fundamental belief in privacy, especially of records, things about your finances, your bank, your social security number. There's a whole breadth of things that we want to keep private. And then each person has a little bit of a different sense of that privacy. I think those of us who have not lived with technology all of our lives, we have a sense that our information is important to keep private. We may have grown up when there was less individual autonomy for women or for various people. So we maybe have been used to less individual autonomy, whereas the new generation is their information's everywhere, but they feel like they should have agency over what's released. So it's really important to understand the different people. You all work in emergency care. You must see everything coming through the emergency room, everything coming through crisis services, all kinds of different people with different needs and wants. And as that happens, you have to think, what matters with privacy? Why do we need to keep things private? And what is the key concern? Is it complying with the law? Or is it making sure that we get the care to the people who need it in a way that respects their integrity, respects their agency? Because that's so important. Next slide. So I always like to start sort of what is the privacy overview, because as we go through these regulations, you all are going to be taking notes and leaving thinking, oh my Lord, what is my checklist? My checklist has gotten so big and so long. But really, when you're thinking about disclosure, think about a recent time when you had information about a patient and their substance use treatment, and you needed to disclose it to someone. So think about that in your mind and think about when you're making that disclosure, when you're talking to somebody else about what you know about a patient, what's the purpose of that? Why are you doing that? Why are you making that disclosure? Okay. And is it really a disclosure or is it someone on your team? So what is the purpose of the disclosure really gets you a long way in what you can and can't do. Then the question is, does the disclosure identify the patient or is the information de-identified? Okay, obviously, if the information's de-identified, there's much more of an ability to share that information. Then the question is, who is the disclosure to? And why are you doing it? So the purpose and who it's to are critically important, and we'll see that play out in some of our hypotheticals and the way the rules have changed. Then, of course, you ask, has the patient consented verbally or in writing? Many of you may not be Part 2 programs. Many of you are HIPAA covered entities. You may work in an emergency room. You may work in a physician's practice. You may work, in a federally qualified health center. You may not be covered by Part 2. So has the patient consented? I think oftentimes we forget that it's the patient. I had a question come about a provider was saying, well, if a patient asks for information in their record, there's a lot that they aren't entitled to. The patient is the one who is the agent for the information in their record and the information you have about them. And that makes things easier, sometimes tougher, but they are really the one in charge. Then a really important thing to remember is that if the disclosure that you're making is intended for the purposes of criminal, civil, or legislative proceedings against the patient, that is a giant red flag. So as soon as you feel like a disclosure you're making about a patient that you've cared for or that you know is to criminal, civil, that includes, child protection, you need to remember the rules on that. And raise a red flag and make sure you're doing the right thing, because that is what HIPAA and Part 2 and most privacy rules are really, really careful about that. The 42 CFR rules protecting substance use treatment records, the purpose is to make sure if people access substance use treatment, they are not made more vulnerable. by doing so, so that people who aren't able to access that information to use it against them in proceedings. Okay. The other question is, has the patient been notified that this type of disclosure will be made in the notices of privacy practices? We'll talk about that. All of your organizations should have notices of privacy practices where it's made abundantly clear to the patient who needs to sign off on them how their information is going to be used. And then finally, but not so finally, this should be question 1, 3, 5, 7. What's best for the patient? What is best for the patient? Because that's what is critical. Next slide. So it's really important to remember the contexts of any privacy rule. We have privacy obligations, as I said, coming at us from all directions in New Hampshire and coming at you from all directions. So, if we were together, I'd have you raise your hands and tell me where you get your privacy rule information. But remember, you've got federal. So you've got HIPAA privacy rules, which are for covered entities. It's for providers who, almost everybody who gets paid by Medicare, Medicaid, or commercial payers submits something electronically and is a HIPAA provider, right? So HIPAA privacy rules cover and protects individually identifiable health information maintained by providers, payers, and their contractors from disclosure, okay? 42 CFR Part 2 protects the confidentiality of substance use disorder patient records from disclosure by Part 2 covered entities, okay? And typically, you need a consent. And then FERPA protects education records. I'm going to touch on these briefly because many of you may be now, as an FQHC employee or mental health provider, or you may be a nurse at a school. Many of you may be dealing with the communications about patients in school settings, in practice settings, in crisis settings, and you're really wondering how these three come into play. So I'm going to touch on that as we go through the rules. And then remember, New Hampshire has its own set of standards and hierarchy about protections of rules. And you all have your licensure requirements, which may put you under a 42 CFR Part 2 framework based on your license requirements, okay? So keep that in mind. And as you're thinking about this, remember, you may also have agreements for your grant funding, et cetera, that really tie you into a context of privacy from a lot of directions. So it's important to remember. Now, it's also important to remember that when we're talking about privacy and consent, sometimes people think of consent. There's consent to treatment, and then there's consent to disclosure. And those are different things. Sometimes we morph them in our minds. So for example, under New Hampshire law, a consent to treatment for substance use treatment, we allow 12-year-olds and older to consent to treatment for substance use. And we also, under state law, therefore, allow them the autonomy to consent to privacy disclosures. So it's important to remember what consent to treatment means, and it may or may not be synonymous with the ability to consent to a privacy disclosure. But you need to have both. A consent to treatment is not a consent to disclosure. Next slide. So HIPAA, we all know HIPAA. HIPAA privacy rules have been around for a long time. And HIPAA privacy rules really do allow for the information of healthcare providers, health plans, and healthcare clearinghouses to be shared without authorization for payment, treatment, and healthcare operations. Okay. And that's really important to remember because the latest changes to the Part 2 rules really tried to get them a little closer to HIPAA, but not quite there. Okay. So HIPAA really controls the disclosure of protected health information created or received by health providers, health plans, and healthcare clearinghouses. Next slide. So many of you are HIPAA covered entities. And this is really important to remember because if you're a HIPAA covered entity and you get access to Part 2 information, you have special rules applied to you as a result. So I just wanted to make sure that you really understand who you are and what privacy rules apply to you. There are always providers who are like, hey, I've opted out of Medicaid, I've opted out of Medicare, I just take self-pay. I really think I'm not a HIPAA covered entity. It is really hard not to be a HIPAA covered entity. So I would assume you are, unless you got some great legal opinion that says you're not, if you are paid for healthcare services. Next slide. So then I'm just going to mention FERPA because we may have, I don't know if we have folks here who work with schools and work with students. And so I just want to touch on the fact that FERPA is education records. It covers identify information in education records. These are federally funded schools. Many schools are federally funded. And it makes education records confidential. And students over 18 or the parents of students under 18 are the ones who control whether or not that information can be disclosed and they have access to it. But remember, healthcare records that are maintained by a school are covered by FERPA, not by HIPAA. Okay, so if a student submits information about immunization or anything else to the school nurse, that becomes an education record. It's not governed by HIPAA. In the thing that happens is that if you're a provider and you are providing care to you may be a HIPAA covered entity with your information covered by HIPAA if you are a school sponsored provider. So if a school asks a federally qualified health center to have a clinic or to have a provider come to the school, it's likely that that information is governed by HIPAA. Okay, so they have separate information covering the separate set of records. All right, next slide. Let's get on to 42 CFR Part 2. You all are probably very well versed in it right now. So what we're really going to focus on is an overview to make sure you haven't been doing things in a way that's inconsistent with the rules and you know what the new rules and the new changes allow you to do, okay? So first, I can't tell you how often I hear, oh, we can't do that because of Part 2, or we can't share that record because of Part 2. Remember that the 42 CFR Part 2 regulations, they protect patient records created by a federally assisted program for the treatment of substance use disorders. And we're going to talk about what that means. Who is a covered Part 2 provider? All right. It covers their creation of these records. I'll talk in a minute about what federally facilitated means, but just let me say, if you are a substance use treatment facility or you hold yourself out as one, or you're a provider that's covered by Part 2, chances are you're federally assisted if you accept any Medicare, Medicaid, or you're a nonprofit and 501c3. So it's a very broad rule. So with limited exceptions, you need a patient consent to disclose, and we'll talk about what that means. Now, you can disclose information based on a consent that allows for disclosure for purposes of treatment, payment, or healthcare operations, which is really helpful, and I'll explain more about what that means. Next slide. So what I'm sure of is that you in your daily practices, I'm looking where some of you are, alternative sentencing, recovery-friendly workplace, LADAX. I'm looking at who you are, and please more of you put who you are in the chat. That's very helpful to me. It is quite obvious that you are sharing information across provider types and across social service types and in a variety of settings that identify the patient and may include information about whether they've had substance use treatment. And so that the rules really do take into consideration that this is possible. It is possible to disclose and get information to the people who need it to help support the patient. Okay. And what you need to constantly think about is what disclosure am I making, why, to whom, and what do I need to make sure I can do it well. If there's a possibility that you can share information about somebody without and do it with a warm handoff without actually giving their name or other things, think of ways to make it possible. We spent so much time in the IDN setting, in the IDN world, of sort of thinking, what do you need to disclose and why and to whom, and how do we make sure it can happen and we have the protections in place to make it happen. So it's much more important to lead with what do you need for your patients? What do you need for your daily work supporting these patients? And then back into how you do it. And that's what's happening right now with the crisis system is we're trying to figure out how do you make sure, the crisis intervention teams can share the information with the people they need to so it works. Thank you for sharing who you are. What a great group of people we have on. Next slide. So what makes Part 2 program records different? There are heightened protections against access by law enforcement and the criminal legal system. To the extent that there anyone from the drug courts on, I promised that I would explain that there is now a special rule 2.35 that gives the parameters of exchanging from a Part 2 program information about treatment to a drug court program or the criminal justice system when somebody is participating in treatment as part of their conditions. So there is now much more clarity on how to do that. Remember also that a Part 2 program records are different because for almost all purposes, other than a few exceptions, the requirement is that there be a written consent to disclose information about a patient from a Part 2 program. Okay, even their identity can't be disclosed. You can't tell someone that they're there and in treatment unless you have a written consent to do so, or for very rare exceptions. Next slide. So let's look at who a Part 2 program is. I bet you most of you know whether you or not you are a Part 2 program, but because of the substance use delivery system and the crisis system in New Hampshire, every year we're doing new things to try and get care to people at the right place in the right way and get them referred to care. So every year it seems like we have a new question. Wow, is that entity a Part 2 program? Are the records they're creating actually subject to the Part 2 rules? So I'm going to go over it, even though we've gone over this many times. A Part 2 program is an individual or entity that holds itself out as providing and does provide substance use treatment, diagnosis, or referral for treatment. Or medical personnel or staff whose primary function is the provision of SUD services. So if you're in an emergency room and you have a substance use treatment personnel who are there solely for that purpose. That's why they're at the hospital. They have a title that associates them with that activity. They come and see patients in the emergency room. They may be creating Part 2 records. That doesn't mean everybody in the emergency room is a Part 2 provider at all. So it's really the Part 2 program are the group of people who are providing and hold themselves out as providing substance use treatment, diagnosis, or referral. Next slide. So now I'm getting to the fun part. Next slide. What's changed and now what with the new rules? How does it impact what you do? So just so you know, these changes were published in the CARES Act back in 2020 during COVID. So we knew they were coming. So many of you may have been given advice to start complying with the CARES Act already. So some of this may sound familiar. The hope was that they'd make Part 2 rules comply more with HIPAA. They do, kinda, all right? The most important thing I'm going to tell you is these rules, new rules, are already effective. April 16th, 2024. But the compliance date is not until next February. So February of 2026. So what does that mean? That means you can do some things to use the parts of these rules that make your life easier and improve your ability to care for your patients. But for example, the complicated notice of privacy that you need to develop doesn't have to be done until the end of next year. Okay. And they're also anti-discrimination rulemaking that is going along with the CARES Act and really is trying to prohibit the use of substance use treatment records to discriminate against patients in healthcare, employment, housing. Those have not been finalized. So of course we can't comply with them. Next slide. Okay, so now it's for your own honesty. You know, I wish I could tell from who you are whether or not you are folks who really have reviewed and begun to implement these new rules, or you're just learning the basics. So if anybody feels like there's an expert, say so in the chat and I'll call on you and you can answer some of the hypotheticals. So if you are at an organization who's already in compliance and you are in compliance, let me know so you can help me through this. Next slide. So I'm going to give you this checklist and then I'm going to go into detail, okay? So this is the key to remember. You now, under the new rules, Part 2 remains stricter than HIPAA still. So if someone told you that now Part 2 and HIPAA are the same, they're wrong, okay? But HIPAA privacy notices can now be amended to include the Part 2 notice as well. You don't have to do it now. You can do it next year. There are going to be lots of forms floating around. There's a lot of detail that goes into these notices, but they can be one big notice. Written consents should be updated to clarify that disclosures will include treatment, payment, and healthcare operations. You really want to make sure your patients sign off to consent for your disclosure of Part 2 information, substance use treatment record information, for purposes of treatment, payment, and healthcare operations. You should know the requirements against disclosure for criminal investigation. That's a red flag. If you get a subpoena, you need to know a subpoena is not good enough. You need a court order. So you really need to make sure you know when that red flag goes up and you get help from your compliance folks, or you know what to do if you're being asked to make a disclosure to criminal, law enforcement, anybody for purposes of any proceedings against the patient. So the other new change is that just like in HIPAA, where you have special protections for psychotherapy notes, counseling sessions, a counselor can in fact segregate and specially protect substance use counseling notes. There are new breach notification rules, much like HIPAA. There's new complaint process, penalties, and enforcement that are now much more synonymous with HIPAA. Next slide. And you guys, I hope you're getting your questions ready because there will definitely be time for questions as we go through this. So I would love to quiz you on whether you know the actual exceptions to the Part 2 disclosure rules. So patients must authorize in a written consent disclosures unless an exception applies, okay? There are no major changes to this, but let's just remember that internal communications, you can share information about the patient within your substance use team, and you can share it with those who are administering your program for purposes of payment or compliance or anything else. So you do have the ability to share with your team information about the patients you're treating if you're a Part 2 program. Remember also, and a lot of people don't know the breadth of this, and it was even expanded, you can share substance use treatment information for audit and evaluation. So if you have a payer, if you have Medicaid, if you have a grant administrator at the state who needs information about what you're doing, you can do that. Remember also, though, you can't just give them the information in an email. You still have all the obligations to keep the information secure, use encryption, etc. But you can make the disclosure for purposes of audit and evaluation. You should certainly ask if you think you're disclosing it for audit and evaluation, you should certainly ask whoever is requesting it to confirm that you can make that disclosure consistent with the rule. Medical emergency, there are exceptions for medical emergency, and we'll go into them. You can disclose if the patient, if you need the information and it's a medical emergency, the patient is in a medical emergency, you can get Part 2 information from a Part 2 provider to help you in that emergency. Now, child abuse and neglect. What do you guys think? Can you report a patient's name to DCYF if you believe there's been child abuse and neglect? I've got a yes. Yes, you can. You absolutely can. What you can't do is provide more information from the treatment record when you make that disclosure until DCYF does an investigation and either gets a court order or a consent from the patient for you to disclose more. But the Part 2 does not prohibit you from fulfilling your obligations to report child abuse and neglect. Court order, we know that, we've talked about that. Remember, you can have business associates. Qualified service organizations is still what they're called, but really it's the business associates. And you can share with business associates as long as they agree to meet confidentiality regulations. You can share and disclose information if it's de-identified. You can certainly share consistent with a written consent if there's a crime on the premises. And researchers amongst us, some of you may be researchers. There are special rules and they've been made much more clear about data linkages and the ways to disclose for research consistent with IRBs, etc. So if you make sure you talk to your legal counsel or you look at the special rules on research, I don't have time to go into them. I also want to make sure, again, that I mention the drug courts. There's new, better rules and clarity about sharing with drug courts. And also, this seems so obvious, but working with the fatality review committees, there's a rule that is much more explicit now, 2.15, that do not restrict disclosure from a Part 2 provider of patient identifying information relating to the cause of death under laws requiring the collection of death or other vital statistics or permitting inquiry into the cause of death. This is going to make it much facilitate the investigation into causes of death. I know there's been lots of questions about that. Next slide. Okay, so patient, if you fundamentally, the way you're going to want to be able to disclose information is consistent with a patient consent. So yes, you're going to have to pull out those wonderful consents that you've worked so hard on, and you're going to have to make sure that they meet your needs under the new rules, okay? Because now you have a much better ability to allow for disclosure for payment, treatment, and healthcare operations. You still need the purpose for the disclosure. But I'll tell you what you can include now. You still need that it's your disclosure, your entity that's making the disclosure, who it's going to be to and from, but it can be much more general. So you have all of these requirements still in your consent, and the rules are very explicit about it, but it's much easier than the old days, 5 years ago, before these rules changed, where you had to identify like the specific person. You can have general identification of the entities to whom you're disclosing. And I'll do some hypotheticals for you on that. Next slide. So for example, the to whom section can now, we know for sure, even though many of us have been doing that consistent with the statute since 2020, we now know based on the rules that you can include treatment providers, payers, and healthcare operators in your to whom section. So the language can be something like, yes, I agree to disclosures to my treating providers, health plans, and third-party payers, and people helping to operate this program, especially for treatment, payment, or healthcare operations. So that you want that to whom, and you want that purpose to include treatment, payment, or healthcare operations. That's really important. It's going to make your life so much easier in terms of disclosures for things that the patient needs. And for facilitating the care. The expiration can be as simple as at the end of treatment, or there can be something that says no expiration. You need to be clear that the consent must include a notice to patient of the potential redisclosure and exceptions for judicial proceedings. These are all in the rules, so it is not that difficult to update your consents, and I'm sure there are going to be form consents going around that do this for you. Next slide. It's really important to remember, and this will be in your privacy practices. So as always, you're going to have to train, update, and train again. The consent, each disclosure made with a patient's consent must be accompanied by a copy of the consent or a clear explanation of the scope. Okay. In addition, each disclosure made pursuant to a consent must include the notice that this is protected by 42 CFR Part 2. Again, we've done this before. You can include the short form, 42 CFR Part 2 prohibits unauthorized use or disclosure of these records. You can put that right on the top of the consent that you're sending with that disclosure. Or your counsel or compliance folks may require, next slide, you to use the long form. Now, I have, next slide, please. I have written the whole long form out for you. You know, I know that we love these slides that just have 1, 2, 3, or, you know, nice pictures of what to do. But I wrote this out because if you read this notice, it really does explain to you what the new rules are trying to accomplish. It sounds like a lot of gobbledygook, but it's really good to have it there because it's helpful. This is the long form you can send with your disclosure, and it really does explain to you that, hey, these records can't be used for any civil, criminal, or administrative or legislative proceeding against the patient. If you're a HIPAA provider, you can redisclose consistent with HIPAA. If you're a business associate, you got to comply with our agreements for privacy, etc. So it really does have sort of your 1, 2, 3 around Part 2 in that long disclosure, but you don't have to use it. Next slide. I'm about to get to the hypotheticals, so get ready. All right, this is really critical. If a consent is signed, a Part 2 program, so your treating providers can disclose treatment records for the patient's treatment in order to seek payment and also for your healthcare operations. Okay. If you do make those disclosures, recipients and business associates can further disclose in accordance with HIPAA. If you disclose for treatment, for payment, and healthcare operations, then the people who get it can then redisclose consistent with HIPAA. Okay. Except if they're civil criminal proceedings against the patient. So what that means is if you disclose pursuant to a consent for treatment, payment, or healthcare operations, that information loses its Part 2 protections. Next slide. Just want to remind you that the rules talk a lot about minors, and so it's very important that you understand in New Hampshire what the capacity to consent is. So the rules basically look to state law if around the definition of minor and who can consent. So if a minor has legal capacity to consent, they can also consent to privacy practices. And as we discussed, that's children 12 years or older. They have made it clear, though, that the minor, even if their age of consent, and they have the right to decide what they want disclosed or not, you can refuse to treat them until the minor patient consents to use or disclosure that's necessary to obtain reimbursement. Unless our law says otherwise. Someone please write, if we think New Hampshire law says otherwise, let me know, but I don't think it does at this point. So you can tell the minor, they may say, look, I'm 13, I need help. Please don't tell my parents or anybody at my school. And you can say yes, but you need to authorize us to at least disclose for purposes of payment. You can do that. Okay. If the minor lacks capacity because of extreme youth or mental or physical condition to make a rational decision, then you can communicate with a parent or guardian or anyone authorized under state law to try and make that consent and make that determination for you. Okay. We're now going to get into the hypotheticals. Next slide. And I just want to let you know, and I put in the chat at the very beginning, hopefully, oops, there it is, that there are a lot of resources now The Center of Excellence, which is staffed a lot by the Legal Action Center, which is a really, really helpful group. They do a lot of education, and you can look at those provisions. And they have been very helpful. I have used and lightly edited some of their hypotheticals, just to be clear. Next slide. I'm going to skip this because this was put out of order, and it's relevant to the HIPAA changes. Okay, disclosures. Frances. Frances is referred by her primary care physician to a recovery center called Recovery for Life. When she visits the program for evaluation and treatment, she signs a consent form authorizing uses and disclosures of her records. And this is what her consent says. To my treating providers, third-party insurance plans, and people operating this program for treatment, payment, and healthcare operations. Okay, so she's got that special language. Next slide. So I'm going to ask you, which of these disclosures is permitted? Okay, by Recovery for Life. We're assuming Recovery for Life is a substance use treatment provider covered by Part 2. Remember, she's got this special consent. So Frances's treatment provider at Recovery for Life can share all of Frances's records with the treatment team and other providers at Recovery for Life. Okay, I want you to write down your answers. Recovery for Life can share all of Frances's records with her primary care physician. Okay, we got a couple yeses for one. How about for two? We got a yes and a no. All right, I'm going to go over these. Recovery for Life can respond to a question from the emergency department at the local hospital when Frances is admitted. Yes or no? We've got yes on 3. A lot of yeses on 3. If it's an emergency. Okay, Recovery for Life can bill Frances's insurance company for reimbursement and respond to prior authorization requests with treatment information. Yes or no? Okay, we got a lot of yeses for this. Number 4, yes. All right, how about this final one? Recovery for Life can provide Frances's information to the county attorney's office in response to a subpoena. All right, we got some no's. Okay, you guys are good. So listen, because the consent says that Frances can share for treatment, payment, or healthcare operations, yes. First of all, without even that consent, she can share with the team at Recovery for Life. So that's okay. Other providers at Recovery for Life. Number 2, can she share with her primary care physician? Yes, that's for treatment. If it's necessary for treatment, remember there is minimum necessary. If the primary care needs to know for purposes of treatment, yes, that can be shared with that kind of consent. Okay? Yes, if it's an emergency, they can respond to a question from the emergency department. But remember, that's an exception that you don't even need consent for if it's an emergency. If you have a consent for treatment, you could disclose more to the emergency room if they are there treating your patient. Okay, so remember that now that disclosure, treatment, payment, healthcare operations makes it much broader what you can disclose without further consent from the patient if they've signed that consent. And absolutely not, you cannot disclose to the county attorney's office in response to a subpoena. They're going to have to get a court order in order to do that. Okay, let's go on to the next slide. So now we have Dr. Caregiver, who is Frances's primary care physician, receives the records from Recover for Life in order to follow up on Frances's recovery. And presumably Recovery Life has done the right thing. They've attached the consent and the special notice that they need to give to the provider when they get that information. How can the primary care practice use or disclose Frances's records? Okay, I'm going to ask these questions. The PCP, so Dr. Caregiver, who now has them pursuant to a consent that says they can share, they received them pursuant to a consent for treatment, can engage in any use permitted by HIPAA. For example, doctor caregiver can share records with Francis's cardiologist in another practice. What do you think? Okay, I'm going to go through these one by one. Yes, they can because of that type of consent. If a HIPAA provider gets the information based on a consent that is for treatment, payment, or healthcare operations, then they can disclose consistent with HIPAA. Okay? How about the PCP can disclose to Francis's health insurance plan to obtain payment for treatment after a retroactive denial of coverage? What do you think about that? Okay, we got some yeses. Yes, if the PCP, let's say there was a heart issue from, treating for substance use or whatever, or some reaction, and they needed to share the Part 2 information that they received for consistent with that consent, yes, they can make that disclosure for payment to the PCP. How about PCP can disclose to the Division of Public Health as part of a federally funded grant program if the records are de-identified consistent with HIPAA regulations? Yes, that old de-identification is now possible. That's going to make things a lot easier. Okay, PCP can disclose to its consultant engaging in a compliance review. What do you think about that? I'm not seeing anything. I've got some no's. Okay, that is also a yes. If the consultant has a business associate agreement, a qualified services organization agreement that includes their obligation to protect that information, a compliance review could be healthcare operations. So if the patient has given consent for payment, treatment, healthcare operations, and the PCP has the information pursuant to that consent, the PCP can then disclose it for under HIPAA for healthcare operations. Okay, so this is a big change, and I know a lot of you have been very, very, very good at making sure the Part 2 obligations track the Part 2 program records. But here, when the disclosure is by consent to a treatment provider for treatment, payment, or healthcare operations, they can then disclose the information consistent with HIPAA. You're right. I have a question. The BAA would not need the Part 2 language in it. That is correct. The PCP can make that disclosure to their consultant consistent with their HIPAA requirements. You could decide as a practice to make sure your BAAs actually say if you get information about substance use treatment, how you want to make sure that's also protected under their obligations. Okay, next slide. There's a question, should include those qualifications first. I'm not quite sure what that question is, so write that out further. All right, now, what if the Division Youth Family DCYF requests Francis's records from Recovery for Life, doctor caregiver at the primary care practice, and Francis cardiologist? So remember, Part 2 provider is Recovery for Life. They're the ones who have maintained it under Part 2. Doctor caregiver now has those Part 2 records about a patient pursuant to a consent for treatment, payment, and healthcare operations. And then Francis's cardiologist got some information about Francis's treatment under HIPAA from doctor caregiver in relation to pending termination of parental rights proceedings. So now DCYF is trying to get information from all of these folks. Who can release Francis's treatment records in response to the request from DCYF? Recovery for Life, doctor caregiver, or the cardiologist? Okay. Think about that. Next slide. All right, let's go through that. DCYF, because this is not uncommon. So for Recovery for Life, Part 2, Francis's records are protected by Part 2. They would need a court order from DCYF to provide those because it's civil proceedings against the patient. or a specific written consent. DCYF usually gets consent from the patient, but you need to be very careful that either one or two of those, the other of those is in existence. Doctor caregiver. Dr. Caregiver, remember, now has these records, but Dr. Caregiver's disclosures are subject to HIPAA. So Francis's records can be used or shared consistent with HIPAA, which Part 2 now says, yes, it's HIPAA, except for legal proceedings against Francis. So Dr. Caregiver's back in the same circumstances, recovery for life, and really should not disclose those Part 2 records without a court order or a specific written consent. Okay. Cardiology practice, which receive them from Dr. Caregiver, now there's no longer any of that Part 2 protection to those records. Okay, so disclosure could be made to DCYF consistent with HIPAA. Next slide.
Professor Hodder, can I jump in for just a second?
Yes.
We had billed this as a 12-to-1. This is fabulous. I propose that we continue if my both partners, associates agree, and this recording will be available at their website. And Melissa has just popped that in, but this is good stuff, and we don't want to let that stand in your way. But thank you, and if we can, if people are able to stay, great. If you're not, the material will be available to you. So
Okay. Are we finishing at 1?
that was the original plan,
Yeah,
but I think there's a lot of.
I'm gonna scoot on through. I'm gonna try and not go much longer than 105. So I'm
Okay,
just
great,
gonna plow on through.
great, thank.
Okay, this one you should all know. Claire calls and makes an appointment with a SUD treatment provider to come in for an assessment. Claire has not yet come in for her appointment. Is her identity protected by Part 2? Next slide. Yes. There's a treating provider relationship with Claire. So by making an appointment, Claire agreed to be assessed and diagnosed. By scheduling Claire for the appointment, they agreed to undertake the assessment. An in-person encounter is not required to establish a provider relationship. And this is really important to understand as we make all these crisis referrals as to when protection of the identity comes to play. I think it's really important to work it out so everything works well. Next slide. Then this is something we should all know as well. Allison wants her Part 2 program to coordinate transportation to and supports from housing helpers. Let's assume housing helpers are not a HIPAA covered entity. They're not a Part 2 provider. And Allison signs a consent form authorizing certain information to be disclosed to housing helpers. Okay, is this permissible? Next slide. All right, we got some good answers. Yes, and I see there's a question. Yes, she can consent to Part 2 treatment records to an entity, including her identity, right? So remember, her identity is covered information. And here the housing service coordinators. You don't have to name a specific person anymore. We know that for sure, not like the old days. Okay, so a question regarding sharing Part 2 information with the vendor of a grant-funded program for purposes of treatment. So I guess it would depend. Is the grant-funded program vendor, are they the treating provider? Are they seeking it pursuant to a consent that your patient has signed? Maybe email me. I will put my email in the chat so we can talk further about it because I don't want to answer a question where I don't know all the facts. But I'm happy to answer questions offline. All right, next slide. Communications during a medical emergency. Can a Part 2 medical emergency exception be invoked to head off a potential medical emergency, such as a potential drug interaction? Okay, next slide. All right, we got some yeses. Yes, even without a consent, if a healthcare provider treating an individual determines that a medical emergency exists, okay, and this is what one is, they can get information about drug interactions or other information they need from a Part 2 provider. They can get that information, write it down. They need to say when and how and why they got the information. So there's certain obligations in the record, but they can get it. Remember also that if you're a Part 2 provider and the emergency department calls or emergency people come, you can share if there's a consent for treatment, and these are treatment providers. So we also have that double ability. Next slide. I'm just going to say quickly, there is no prohibition against sharing information from one social service agency with another social service agency. They just need to have their own privacy practices. They're not if they're not treatment providers and not Part 2 providers, the fact that somebody might be in getting treatment and that they know that is not all of a sudden become Part 2 information. They have to use their discretion. But let's say a social service agency learns that one of their clients is actively in treatment. That information doesn't become specially protected unless that social service agency has special rules to do that. Okay, it doesn't become a Part 2 record just because anyone in the world learns that someone is getting substance use treatment. Okay, it really matters where that record and information originates. Next slide. Okay, so we're done our hypotheticals. I know we should do many more, and we could certainly schedule another session and do more. We have some time before you have to get all this worked out. So I'm just going to tell you a couple quick highlights and then let you go about your day. But there is a special rule now to protect counseling notes. Again, it's much like the HIPAA psychotherapy notes. Note that the counseling notes, they're not going to be the exception that swallows the rule. So the counseling notes are just those that are created by a provider who is providing counseling, and they're treatment notes. Okay, it doesn't cover Medicaid prescriptions and monitoring, counseling sessions, start and stop times, the modalities or frequencies of treatment, results of clinical tests, et cetera, et cetera. So the counseling notes are just counseling notes. Next slide. So you can decide to separate them from the Part 2 records. You all are going to have to think about what you want to do and how you want to deal with counseling notes. Next slide. Okay, so we're going to wrap up pretty soon here. I just want to make sure you all know that there are really intense rules around what your notice of privacy practices must include. And the reason for that is they now can be combined with HIPAA notices. And they're not, they are very similar to the HIPAA notice requirements. And so they're going to be combined HIPAA Part 2 notices that are going to be really useful to use. SAMHSA and OCR, who's now enforcing these rules, have promised to come up with draft of notices. So I would say don't revise your notices yet. Wait till we're closer to enforcement deadline to do that. Do remember, though, that if you change your consents to allow for disclosure for treatment, payment, and healthcare operations, when you make a disclosure consistent with the consent, you should attach the consent and either the short or long form of the notice, those magic words. Okay. You do have to account for disclosure that are made electronically, consistent with an electronic health record. You must allow for a process for patient complaints, and there's now breach notification. Okay. I have one more slide, but I've just gone through it. And what I'm going to tell you is these rules are intended to be helpful, and I'd be happy to help with how things come up and the way things come up and how to facilitate treatment. What is most important is the agency of the patient, and that the patient is in control and understands what's happening to them and why, and that you get their consent if at all possible. So it's one, and I'm done. I was gonna, if we had time, tell you about the new HIPAA rules protecting reproductive health care, especially, and those are in effect too. So maybe that's for another day. Really important to understand that protection, again, against the requests of law enforcement, especially from other states where certain reproductive health is unlawful. There are heightened protections now for against disclosure of reproductive health care records. So be well, have a wonderful holiday. Thanks for listening in to this. I hope this was helpful, and wish I could see all your faces, but I see a lot of your chats, and that was really helpful to me, and we'll talk soon.
Lucy, thank you so much. On behalf of the community practice, I've sat through literally dozens of these, and absolutely top tier quality. And No surprise to me, who has known you for so many years, but I think for um, just thank you for a tremendous presentation.
Okay, just show the last slide, Danny, just so everybody has it before they go. Right. Mark your calendars for future updates. There you go. That's the key takeaway. All right. Bye. Do you want me to
Thank
Thank
stay
you.
on, Dan?
That's all I had to say there. I think we usually move into a discussion about following up in the communities of practice and where you can
Okay.
access this information. And
Yeah.
if you would like to do that, that's fine. This is it. This is where you can go to find out more information, as well as the recordings of all of the past communities of practice for this and for all of the other communities of practice which Growth Partners supports and does so very much for us. Melissa, did I miss anything there?
Yes, we have we need to put the evaluation link in the chat. And that is how you will be able to get a certificate of attendance by completing that. Danny, I don't have a way to copy that. Can you put that in the chat for me, please?
Yes, doing it as
Thank you. There we go. Yeah, it's just a quick 5 or 6 question evaluation. And we won't have certificates ready until probably the first week of January. So thank you, Lucy, so much.